We'll give this just a few moments and then get going. May as well get going. Okay, this was a Zeopatch recording that was sent to me by a colleague asking my opinion. What do you think we're looking at? And what, if anything, should we do about this? Christina, what do you think we're looking at here?
Morning, Dr. Pass. So Zeo in the Zeo strip, in the top line, you can see a segment of the strip that's below. And so looking at it, first, wanting to make sure there's a P wave before every QRS. Which I can see, but then going into in the middle of the segment, you can see that it looks like there's no QRS, or sorry, no R wave after the P wave. So
Mhm.
it makes me think, is this something like a blocked PAC, or is it AV block? So now looking at it more, um, trying to ascertain which of it is. And I would say it looks like more like Mobitz or type 2
Now, why do you
AV
say type
block.
2? Wait, did you say Mobitz type 2 Wenckebach? Did I hear you saying?
Well, so I'm trying to ascertain if it's a Mobitz type 1 or type 2 Wenckebach, or type 2, and looking at the P wave to see if there's any the PR interval, to see if there's any prolongation before we lose that R wave. And it's hard to tell. If I had calipers, and I could, you know,
Right. So do you think this PR is the same as this PR?
it looks like it's getting longer in that bead, and
Yeah.
then it looks like it's getting longer. So it looks like it's Wenckebach.
Yeah. So just for clarity, Wenckebach is Mobitz 1, but Mobitz 2 is not Wenckebach. So what Mobitz 1 and Wenckebach are basically synonyms. And so yes, I would agree that this is an example of Wenckebach. And one of the sort of little I would say clues is if you look in the tracing below, which is giving us a larger sampling, you notice that there's grouped beating. You see like 4 or 5 beats together, and then a pause, 4 or 5 beats together, and a pause, 4 and 5 beats, and a pause. When you see group beating, oftentimes this is consistent with a diagnosis of Mobitz 1 or Wenckebach. So you obviously have to look at the tracing itself in order to, you know, uh, confirm. But when you start seeing this type of pattern with such consistent grouped beating, where you have a couple of beats together and then a pause, couple of beats together and a pause, oftentimes that is associated with or is due to Mobitz 1. So should always keep that in mind when you're looking at a tracing like this. And so if you saw that somebody had Mobitz 1, Christina, anything you would do about this?
So I'd want to see when it's happening, during the
Right.
day or at night. If it's
Mhm.
happening at night, I would, especially in a young child, toddler, I would think it could be just due to a high vagal tone. Um, in a
Yeah. I mean, this,
in an older patient, it could be an athlete and well conditioned, so you could see it as well.
yes, I think that's all correct. Thank you. In little kids, sometimes this could be normal. It could be associated with, what can cause high vagal tone. Maybe somebody is got reflux, and in little babies, you sometimes see this. But this would not by itself be a rationale to do anything other than to surveil for higher levels of block. And so we talked about this last week. Is this typically most of the time when someone has Mobitz I, is it usually at the level of the AV node or is it infrahischian, lower down?
It's at the level of the AV node.
Yes, so that's exactly right. So AV node is usually the culprit for Mobitz one. We did show a strip last week where we had infrahischian Mobitz one or infrahischian Wenckebach, which is unusual, but this would be almost always AV nodal and generally connotes a more positive uh, expectation and prognosis. Okay. All right, let's move forward. So this is a tracing obtained. Um, and the question I have for you is, it seems to be from 10:30 at night. Is this third degree block? The computer is calling a third degree block. Um, is it third degree block? Why don't we ask Dr. Capon what she thinks?
Good morning. So first off, it's a pretty short strip, so I think that will kind of pose the challenge to determine if something is third degree. Often it's hard to distinguish um, high grade second degree block from third degree block in short rhythm strips.
That's
Um,
true.
a couple of things that kind of stand out for me. So it looks like the first three beats or the first three QRSs, or actually the first four, looks pretty similarly spaced. But then it looks like there's one QRS, the fifth one, that kind of gets pulled in.
Mm-hmm.
So when I see that, that kind of makes me think maybe this is more a high grade second degree type block.
Yes.
So right off the bat, that's kind of where my mind's going, but I'll try and tease out the P's and the QRSs. Um, yeah, so I think this is high grade second degree rather than third degree for that reason.
Yeah, I agree with you. And that's the important point. So we have discussed in the past that when a patient has complete heart block, one of the clues or tells that it is complete is that you see a very regular R to R interval. It may vary by a few milliseconds, and certainly over long periods of time, people in heart block can have variability of their ventricular escape rate. But the point is, just as you said, if that were the case in a single strip like this, which we're talking about 6 seconds here, we would expect that the R to R would be fairly stable throughout this tracing, but it is not. It's this beat here is early relative to all the other QRSs. And obviously, as you said, longer strip would make this more obvious, but the fact that there is a QRS that's coming in earlier and is following a P wave, presumably with a very long PR interval. The other thing that's an interesting clue is, and it's hard to say in 3 leads, but there's a suggestion that maybe this QRS is different than this QRS. I don't know if I would hang my hat on that. It's kind of similar, but it would be interesting to see a 12 lead of this phenomenon. But the bottom line is, the point of this slide is to remind that when somebody is in complete heart block or third degree, they usually have a very fixed R to R interval, at least in a given time period. And when you start seeing a lot of variability, you have to be very concerned that there is, in fact, conduction of some sort. It might be bad conduction, it might be high grade second degree, as you just said, Yvonne. I think this is an example of high grade second degree block, but this is an important distinction, particularly like if this were a post-op patient, this would actually, and it was somebody who had third degree and then started doing this might be a potentially, positive sign that something positive, this might be a good sign that there is, something coming. So anyway, something positive coming. Certainly, if I saw this on post-op day 4, for example, I would be marginally more optimistic that there is at least some conduction trying to come through. All right. Any questions about that? Okay. All right. So this is somebody who just had an ablation. This is a case I did many years ago. And this is the rhythm that they are in after the ablation. I'll tell you the ablation was successful. So my question to you is, any thoughts on what you think the ablation target most likely is based upon the rhythm that we are seeing here? And I'll just remind everybody in this drawing, we're tracing the first 4 leads are ECG, 1F, V1, and V6. The map is the ablation distal and proximal, distal to proximal His, actually, I'm sorry, HRA, distal to proximal His, and then the CS displayed as we're used to seeing it, proximal to distal, and then finally RV apex, and there is no stimulation going on. Anybody have any thoughts? Let me see if Molly, do you have any thoughts on what we're looking at? What is this rhythm we see here?
Hey, good morning.
Yeah.
Let's see. Um, I'm not fully certain, but let's take a look. Um,
Is the patient in sinus rhythm?
no, I don't. I think it looks like a junctional rhythm to me.
Okay, I agree with that. That is a junctional rhythm. Is there any intracardiac evidence to support that statement?
To support me saying junctional?
Yes, I agree. The ECG looks like it, and it is in fact junctional. But my question is, do we have any intracardiac evidence of that? When you're in junctional rhythm, what do we believe is firing faster than the sinus rate?
Right at your junction. So,
But what in the junction? Let's get
um,
electrophysiologic today.
I guess it'd be somewhere with your hiss, but I'm trying to figure out what I'm seeing there.
Well, what is the other name for junctional ectopic tachycardia? If you were working in the UK and you had a patient with jet, what do you think they would call that tachycardia? There's another name for jet.
Mm,
Do they call it? It's a multiple choice.
oh, goody.
Is it AV node tachycardia or His bundle tachycardia?
Hiss bundle.
It's His bundle, yes. So in general, when someone's in junctional rhythm, we believe that the His bundle is firing at a
Hmm.
rate faster. So is there any evidence of the His leading the charge in this rhythm? And I might add, this is a
Oh,
low
yeah.
rate. This is like a rate of about 70 or 60.
So, yes, because you're seeing, I think where you see that the most looks like in your distal, that deflection there.
Mm-hmm. Yeah, this is the His deflection, followed by a ventricular electrogram.
Mm-hmm.
And presumably there's an atrial electrogram superimposed on this,
Mm-hmm.
potentially, so remember when you're depolarizing the His, it's going down, the conduction is conducting down, and then it's also conducting up, right? Because the
Mm-hmm.
His is in between both. And so so we see here the map has an A, I'm sorry, the high array, let's look at the high array. High array is in the high array, obviously, and we see that it's almost simultaneous with the V. So you can think of the His as firing and simultaneously sending the impulse both up and down. And that's the reason why the A and the V are sort of on top of one another in timing. Similarly, in the coronary sinus, right, normally we're used to seeing an atrial and a ventricular electrogram. We're seeing the two of them smushed
Yeah.
together because we're going both down the AV node and up the AV node at the same time, or down to the ventricle from the His bundle through the His-Purkinje system, and then up through the AV node back to the atrium. And so they're all sort of simultaneous. So we have established correctly that we're in junctional rhythm. Is there any, based on this, do you have any thoughts on what the possible ablation target was in this patient? This was immediately after an ablation, a minute or two after the ablation.
That would make me think then potentially that you were ablating for AVNRT.
Yeah, that's exactly right. When you have an ablation for AVNRT, it's often the case that we see junctional rhythm afterwards as a just as a sequelae. Remember that when we're using RF to do slow pathway modifications, we in fact see junctional acceleration. But after an AVNRT ablation, it's not uncommon to see junctional rhythm. Now, obviously, you would want to confirm that the AV node is working. Remember, in junctional rhythm, Molly, can I tell if the AV node is working antegrade?
Um, Not well, but we're seeing it go both ventricular and to the atria.
But where is the bundle of His relative to the AV node in the conduction?
Oh yeah, still yeah. So no, you can't.
You can tell it's going retrograde, right?
Right, but you can't. Yeah, yeah, yeah.
But you
But you
can't
can't
tell it's
tell.
going antegrade.
Yeah,
So when I see this after an ablation, I am pleased, but I want to be sure
not out of the
that,
woods yet. Yeah.
yes, I want to be sure. Now, a lot of this is an interesting observation. So I know most of you know that when both Barry, I think I do this much more than Barry. When I see junctional rhythm during an AVNRT ablation, a slow pathway modification, I will usually pace the atrium. And the reason is I want to confirm that I am not injuring the AV node during the delivery of radiofrequency current. But a lot of electrophysiologists, in fact, I think I would be fair to say that most electrophysiologists will use the presence of VA conduction, which we see here, right, or His A conduction, as a surrogate for AV conduction. The theory being that if you can conduct retrograde through the AV node, right, because presumably we're in junctional rhythm, so we're starting at the bundle of His, we're going down the His-Purkinje system and up the AV node to the atrium. So most electrophysiologists will say that if I see retrograde conduction through the AV node, then I know that there is antegrade conduction through the AV node. But that is true most of the time, but not 100% of the time. And so because of that, and in fact, that's the reason why we've talked in the past that people can have this condition called pacemaker-mediated tachycardia. So when patients have pacemakers, they have AV block, right? That's the reason we put them in usually for complete, if someone has heart block. But rarely what can happen is patient can be paced in the ventricle and it goes retrograde through a still intact retrograde AV node. Then the atrial lead senses the retrograde A and then paces the ventricle to it so that you have a form of tachycardia where the antegrade limb is through the pacemaker and the retrograde is through the AV node. And pacemakers actually have features to interrupt that from happening by lengthening certain intervals intermittently. But the point is, the fact that that can even exist is a good indication or proof that you can sometimes have antegrade block, but still have retrograde conduction. Usually they go together. I'd say 99% of the time, if you have retrograde block, you also have antegrade block, and the reverse is true. But very rarely it's not true. And so that's the reason why I always pace when I see junctional rhythm during an ablation. And so if I saw this, I would be comfortable knowing that this is probably a positive sign, but the next thing I would do is I would ask somebody to pace the atrium at a rate faster to confirm that the AV node is in fact functional. Usually after AVNRT ablation, you see this for a short while and it goes away. In the past, when we would admit patients overnight following ablation, which was quite routine up until about the mid 2000s, we would see this very often, all night long in people who had AVNRT ablations. And sometimes it would get a little scary looking, but it always resolved, and 99 out of 100 times AV conduction was perfect. So, okay, good job. All right, so we're looking here at a tracing from an old book. Patient is sleeping. What's going on here? Let's just say, for the sake of discussion, that this is a 14-year-old. And this is seen at 3 in the morning while the patient is asleep. So, Mohammed, do you have any thoughts on what we're looking at here?
Good morning, Dr. Pass.
Okay.
So I think it started as sinus,
Mm-hmm.
and then the white KRS, I assume, are PVC. So they're seeing 4 beats. I would call them non-sustained VT.
Okay, well, is that VT? How fast or slow are those
Uh,
beats?
Not, it's almost as fast as his base rate. So it's like 70. So it's not VT.
Is it faster or slower than the base sinus rate, do you think? I know it's hard because you don't have calipers on the screen, but I think through your eye you
Maybe
can
a,
guess.
maybe a little slower.
Maybe a little bit slower. So I agree, it is ventricular, and we know it's ventricular. Why do we know it's ventricular?
Well, I'm not seeing any P waves and
Right. And what else
QRS,
about it?
white QRS is.
Yeah, wide QRS, it's completely different than the sinus. So what so how would so you called it VT. I would not
Uh,
call this VT. What would you call this?
um,
EP is a lot about nomenclature. So
uh, is it? Is it idioventricular rhythm? Or,
yeah, you could call it that. I mean, I think normally we would just call this a ventricular escape rhythm. It's actually happening because, right, if we look at the sinus rate, it's varying a little bit, but the sinus rate is there's no P wave.
going?
So this is sort of like a ventricular escape rhythm because the sinus P wave came in late. There's a suggestion that maybe somewhere in here there is a P wave that's happening during the QRS. Similarly here, eventually the sinus rate accelerates and takes over again. Um, so anything you would do about this? So this is a Zio or a halter that was placed for an unrelated matter, and you just noticed this happen at 3 in the morning in this 14-year-old patient.
I think if he's asymptomatic, it can be normal if he's sleeping.
Yeah, I think that's right, Mo. I don't think we would generally do much about this. I think we could make the argument that this is a normal observation. Or maybe I would say it's an abnormal observation, but not particularly dangerous one. We don't normally see this, but on the other hand, I'm not sure what this means. Um, sometimes cardiologists will ask me, do they need to repeat this? I might do it one more time at some later date just to confirm that the sinus node is okay. I mean, another way of inferring that the sinus node is okay is just looking at what the sinus rates are over the heart rate trend. I mean, if when this patient is awake, they have normal heart rate variability, that their heart rate goes up very high when they're exercising or have a higher adrenergic tone, I would be much less concerned. So could this be a sign of sinus node dysfunction? Maybe, I don't know, but this is not an especially worrisome finding. So I think anything from doing nothing to surveilling it a little bit more are both reasonable options depending on your level of concern and anxiety as the doctor. Okay. Right. what would you do about this Fontan patient? He is 34 years old, and this is what is seen. So, Dr. Obsikov, what do you think we're looking at here?
Good morning. I'm seeing multiple different things. Initially, looks like at 7:05, this patient was having tachycardia.
Mm-hmm.
I think I can see some P waves before every QRS. So this I would just on this one strip, it's probably sinus at rate of about 150.
Well, let
Um,
me ask you a question. We'll stop right there. What's the likelihood that a 34-year-old Fontan patient can get their heart rate to 150 with any kind of exertion?
I think it's very unlikely.
Very, very unlikely. So when you see a heart rate that fast in a Fontan patient, you should always have a very, very skeptical eye for the possibility of an atrial arrhythmia. I agree. If this was a healthy 34-year-old who did not have a Fontan, it could be a 34-year-old playing basketball with his friends, or on the soccer field or something. But I think for a 34-year-old Fontan, it would be unusual to see the heart rate that fast. So it's possible it's sinus, but you definitely need to think strongly. The burden of proof is on us that it is sinus and not something else. Sorry to interrupt.
It's okay. Then the next strip, you can't really see the QRSs too clearly, but from what I do see, it does look it's not a regular rhythm. Um, and the P waves, it almost looks like there could be, yeah, and exactly where you're pointing that there could be multiple P waves. It almost looks like flutter, but it's not the clearest. And
Do you
then,
think that looks like a regular
no,
heart P to P, or is it
no, I would
look
say
irregular?
the I'd say the overall rhythm would look irregularly irregular, like an A fib, but the
Mm-hmm.
way the P waves look maybe like they're a little bit like flutter in that one section, but
Right. Remember that
um
we discussed last week how when people have a fib, sometimes the right atrium and the left atrium look differently. And I think that's why in the old days, somebody might refer to this as like fib flutter. That term has fallen out of favor because it's kind of a bullshit term. But I think the bottom line is it's probably some kind of atrial fibrillation, right? The P wave is changing, the P to P is a little variable, the R to R is variable. So it's highly suggestive of that. And then what happens on the next strip?
and then looks like it starts off the same, and then you just have asystole, and then for a long time,
Mm-hmm.
and then you have a I don't say a P wave, so I say junctional
Mm-hmm.
escape beat, and then the last strip, it again looks like that irregular rhythm with a longer period of asystole and then a junctional rate until the very end where it looks like there's P waves.
Okay, so agree with all of that. So is there a term for people who have fast heartbeats and then very, very slow heartbeats like this? It's an old-fashioned term, but I do believe it's still rarely used.
Mm,
So
I'm
some
sure there's a term, but I
some
don't know it.
people would call this tachybrady syndrome, where you have a lot of tachycardias and some bradycardias, and it's usually seen in people who have sinus node dysfunction. And this is not completely unusual in a Fontan, right? We know that Fontan patients have, I mean, look at this rate. I mean, okay, the patient is asleep, but first of all, of course, we have this massive pause, which sort of suggests that, well, part of it is that the sinus node is likely suppressed from the fact that you were just in an atrial tachycardia. So we'll give them the first, 3 seconds of pause, but all the rest of it and these very slow junctional recovery beats, I think, are all suggestive of the fact that the patient's sinus node does not work especially well. Um, so, what do you think? What would be your first move in a patient like this? Patient, so you see this, you're a little nervous, you call the patient says, I feel fine. Then they come in and they're in sinus rhythm, or actually, let's make it, they're in junctional rhythm at 52, which is pretty much what they always are when you see them in the office for the last 10 years.
I would want to do an echo.
Okay, what are you doing an echo for?
Wanna
What are you searching for?
I want to see, this is a 34-year-old patient, so I worry about the longevity of their heart, and I don't know if this type of syndrome could be associated with, an early sign of um, decreased function or some other I don't know
Well,
if
what
there's
percentage of Fontan patients at 34 do you think have sinus node dysfunction?
majority.
Right, a high majority. Now, we don't really know what 34-year-old Fontans with extracardiac Fontans are going to be like. We're hoping they're going to have more sinus node function than others because we're not doing as extensive atrial surgery, but they've already had 3 open heart surgeries at minimum. So they all are going to have some degree of sinus node dysfunction. Um, okay, you do the echo. It looks pretty much the same. Function is preserved. You don't see a large thrombus. Of course, we know that a transthoracic echo is not good to rule it out, but it can rule it in, but not rule it out. And the patient is on anticoagulation anyway because has a good
Hmm.
ACHD doctor. So anything else you could do for this? What do you think about putting him on an antiarrhythmic agent?
I think if it was just like an atrial tachycardia, sure, but I don't know, I've never
Well,
seen the signs of
what would be your concern though if you put him on a medication? I agree that there's probably a role for some medical therapy here, but what could happen? What's one of the more common side effects of virtually all antiarrhythmia medicines?
sign of bradycardia, so I don't want to
Tachycardia.
exacerbate
Yeah,
that.
exactly. I mean, I think the point I'm trying to make here, and I'm sorry, this is a little bit of guess what I'm thinking, which is a bad kind of question, but the bottom line is that when somebody has these types of pauses and has a known history of sinus node dysfunction, this might be considered an indication for a pacemaker. We always drag our feet in Fontan patients regarding pacing because we understand that most of the time Fontans need to have epicardial pacing, which is a big deal. It's hard to find a spot that is will capture. Um, in general, when Fontans are paced, outcomes are much worse. There's lots of studies showing that survival and long-term outcomes are bad when you need to be paced as a Fontan patient. But having pauses of 11 seconds with some regularity and having tachybrady syndrome is bad. And sometimes when you have consistent atrial pacing, it may suppress atrial tachycardias. And many Fontan patients, if they're atrially paced, will have at least a reduction in their amount of atrial arrhythmia, possibly even complete suppression. I follow 1 or 2 patients who basically are completely free of arrhythmia for 5 to 10 years at a time when they're paced. But when they're not, they're in junctional rhythm and they do have IART with some regularity. So I think in this case, with this type of pausing, with this type of arrhythmia, I would say the first step would probably be to put a pacemaker in this patient and bite the bullet. And usually when we do this, it's done as an epicardial system because we're worried about paradoxical emboli. Obviously, it's very hard to do an endocardial pacing in someone who has a single ventricle. Risk for thrombus and stroke is extremely high. Even doing atrial pacing transvenously is generally looked down upon because oftentimes Fontan patients have baffle leaks. Also, almost all transvenous leads develop thrombus on them, even in healthy patients. The implications are very minimal in a 2 ventricle patient, but in a Fontan, if you had microemboli going to the PAs, that could be very bad for your hemodynamics. We do sometimes do that in rare cases, but we try to avoid it. So this would be a patient where we probably would have to have a long conversation about doing a thoracotomy and putting in a dual chamber pacemaker. And oftentimes in Fontans, it can be very difficult to place an atrial lead. Ventricular lead is not usually too hard, But the atrial lead is hard because the right atrium is usually very scarred from multiple cannulations and surgeries. And one of the tricks that surgeons will sometimes do is to try to do a left thoracotomy and try to pace the left atrium, because probably the LA is one of the few areas in most single ventricles that have had fairly minimal surgical intervention on. And so usually the tissue there is relatively pristine, and it's easier to place a pacing lead that will have good capture and sensing. So it's not uncommon in this setting to have the surgeon do a left lateral thoracotomy and place both an LV or a lateral ventricular lead as well as an atrial lead. Okay, any questions about any of that? I think if that's the case, we'll stop at this point. Thanks for joining, and I hope everyone has a great day. Have a good day. Bye-bye.
Thank you.
Bye.